Hi, everyone. Welcome back. My name is Deepti, Dronamraju. I'm one of the hepatologists here. I'm going to be moderating session 3, which is updates in the management of chronic liver disease. We're going to shift around the order of the talks, and our first talk is actually going to be treatment and transplantation for alcohol-associated liver disease, and it's going to be given by Dr. Allison Kwong, who is an instructor of medicine here at Stanford and is one of our great researchers in outcomes research and does research in alcohol-associated liver disease. So without further ado, here's Allison Kwong.
All right, this is the benefit of showing up on time is I get to go first, and I think I have unlimited time until our next speaker comes, although so we're not talking about cholestatic liver disease. I get to talk about treatment and transplantation for alcohol-associated liver disease. So we'll start by saying a lot of what these slides come from the ASLD practice guidance that was released in 2019, which is the latest update. So if you need a reference in the future for anything clinical, this is where it comes from. So this is one of many practice guidances that are available from the ASLD. We'll go through today, before we get into treatment and transplantation for alcohol-associated liver disease, just a bit of nomenclature and diagnosis to understand what we are treating, but we'll focus mainly on treatment options and transplantation. The main takeaway from the ASLD practice guidance from 2019 was actually a name change. The recommendation was to take away the word alcoholic, as that would be considered stigmatizing. So now, as much as we are able to, we are referencing alcohol-associated liver disease and as cirrhosis and hepatitis, where applicable, it's more of a mouthful, but more accurate. Just a reminder that alcohol-associated liver disease is a spectrum of disease. There is fatty liver, steatohepatitis, fibrosis, cirrhosis. These can usually, with liver disease, it's more of a progression that happens over years. But in alcohol-related liver disease, you can get one or several coexisting processes. And so when we're talking about treatment, first you really need to understand what you're treating. Are you looking at alcohol-associated liver disease with or without the presence of hepatitis or inflammation? Is there an inflammatory component that you can treat? Usually, actually, there's a little bit of both when we're seeing patients, these patients. So I do use the NIAAA definitions to clinically diagnose alcoholic hepatitis or alcohol-associated hepatitis. This involves a really recent onset of jaundice with recent alcohol use, and then certain laboratory parameters, including a bilirubin over 3, a modestly elevated AST with a ratio greater than of AST to ALT greater than 1.5. So when we're treating alcohol-associated liver disease, this is a reminder that there are almost always two diseases to treat. There's the liver disease that's in front of you, but then also likely years of heavy alcohol use and alcohol use disorder that also needs attention. This is because the most effective therapy for the liver disease is abstinence from alcohol. You can see this is in patients with severe alcohol-associated hepatitis who are hospitalized. The long-term outcome over up to 5 years, you can really make a difference if you are able to abstain from alcohol. The magnitude of this different, and the patients who continue to drink or relapsed after initial abstinence had much worse outcomes. So this is the most effective therapy, and the best thing you can do or your patients can do for themselves. The magnitude of this improvement or difference in survival is much greater than anything we can do pharmacologically. So how do we do that? You treat the underlying alcohol use disorder. This table is from the practice guidance and outlines some of the main medication-related or medications that you can use to treat alcohol use disorder and reduce cravings. Naltrexone is one that's probably most effective, but generally it has been underused, and hopefully we can use more now that the black box warning for liver disease has been removed. But so historically, we've kind of been stuck with acamprosate, gabapentin, baclofen, even though the data is more limited. The majority of our patients still either aren't on pharmacologic treatment or don't want to be on it, so it's not the only therapy that's available out there, but the key is to get these people into treatment for their alcohol use to try to maintain abstinence as much as possible or get them close to that. That's the best thing for their liver disease. So at the minimum, you really should be screening all these patients for the alcohol use disorder and referring them to treatment. And you can do a very simple screen. The audit C is just 3 questions saying, how often do you have a drink? How many drinks? You can see with these questions that almost all the patients we see who are hospitalized with alcohol-related hepatitis or have such bad liver disease from alcohol that they're seeing us will qualify for or will meet criteria for moderate or severe alcohol use disorder if you're drinking daily and more than what's recommended, which is 1 standard drink for women a day and 2 for men, or for women and then 2 for men, which is probably less than you think it is. But definitely get these people into treatment. So we'll talk specifically about treatment for the liver disease, and we really have treatment for the hepatitis component. So again, identifying that there's an inflammatory component to treat, conventionally we've all calculated the discriminant function that's based on the prothrombin time and the bilirubin, and that threshold of 32 is considered to be severe enough hepatitis that would benefit from treatment. And by treatment, we mean really the only therapy that's available is steroid or prednisolone at a dose of 40 milligrams a day. The discriminant function is a bit old. It still kind of stands the test of time. We've been using it for 40 years, but there's some evidence or newer practice that MELD may be a better predictor. So a MELD score of above 21 to really above 25 may correlate to this severe alcohol-associated hepatitis that would benefit from prednisolone. If you have lower than these thresholds, it doesn't mean you don't have alcohol-associated hepatitis. It's just a more mild or moderate case, which really should improve with supportive care and abstinence and isn't worth steroid therapy. This is the standard duration for corticosteroid, and we'll get into a bit of the evidence behind steroid use. The standard duration is 28 days at a dose of 40 milligrams a day. I find prednisolone and prednisone to be actually clinically interchangeable. If you dive back into the evidence from why they chose prednisolone, the first-pass metabolism is kind of a theoretical thing, less so seen in practice that really makes a difference. So I find them interchangeable. Really importantly, when you're starting therapy, you really want to make sure that these patients can get an allele score calculated at day 7. That's a score that's comprised basically of the baseline values plus the bilirubin at day 7 to see if there's a response. If there's no response, you don't need to and should not expose these patients to 3 more weeks of unnecessary steroid treatment. And there's evidence now that day 4 is just as good as day 7. So if you still have them in the hospital or are able to get an earlier value, you can even stop steroids at that point if they're not responding. Important to remember that there are contraindications to steroids in the studies. They didn't use it and we shouldn't use it in the setting of infections. It wasn't studied in renal failure with a creatinine over 2.5, GI bleeding, pancreatitis, or multi-organ failures. So there are certainly contraindications that you need to be mindful about. Here's the benefit of steroid. This is over 10 to 15 years ago, several RCTs showing that if you were able to complete the steroid course, you can improve your 28-day mortality in alcohol-associated hepatitis from about 66% to 80%. So it did seem to work or have some effect, and that's how it became standard of care. This is more recent data from the STOP-AH trial. This is also an RCT. These lines are much closer together in a at least unadjusted way, no difference in with steroid therapy or not. Some changes in design and maybe a different population, and there was maybe some statistical significance, some improved 28-day mortality, but this is a recurring theme. There's no difference in long-term outcomes. So the evidence here from this study show it was a bit weaker for steroids. And so as a result of this and some more recent data, I'm not heartbroken if the patient can't take steroid, or I'm less likely to prescribe steroid. A couple more recent studies, again, building a weaker case for steroids. This looked at kind of the MELD threshold where steroids might be beneficial, and it really is above between 25 and 39 that you get the most benefit. Anywhere 20 to 21, 20, 25, maybe a little benefit, but really trying to identify a range of MELD where steroid makes sense. This study came out last year from the UK. Actually, the UK, they had stopped, after the STOP-AH trial, had stopped prescribing steroid for alcohol-associated hepatitis. That's how confident they were in that result. So this is a natural history study, and I really like this because you can actually save people or not prescribe steroids by identifying this fast follower group. These are people whose bilirubin just naturally comes down with abstinence and supportive care and do not need steroid therapy. And they say, if up to almost half of patients with a discriminant function of greater than 32 or MELD over 20, so these are people you would have prescribed steroids in a different country or a different setting, they don't actually need it and they would have gotten better already. So the takeaway from this has been if you, not that you can actually wait to start steroids, give it a few days, make sure they're not infected, and have some patience, and maybe if their bilirubin's already falling, you don't need to add steroid on top of that. Just a summary of treatment. Again, I've only talked about prednisone. That's because it's the only thing we really have, at least pharmacologically at this point. The full course being 28 days, but abbreviated course or none at all might be even favorable. But for all these studies, we're seeing that 28-day survival it could be improved marginally with corticosteroid, but really does not affect any outcomes longer than that. Really, the key for long-term outcomes is abstinence from alcohol, however you can support that. There are a lot of studies that have been negative, trying to find a better treatment for alcohol-associated hepatitis. Most of the trials have been negative. Pentoxifylline, which used to be part of the standard of care bundle, was proven not to be, so that's no longer, that's why it's crossed out. Some early evidence for the combination of prednisolone and NAC or GCSF, but that's not really, still not mainstream and probably won't be. And clinical trials, the closest one being this larcusosterol or oxysterol molecule, which we have we are one of many sites that have this, and hopefully it's in phase 2B, and hopefully will complete enrollment this year. When you're talking about treatment for, any alcohol-associated liver disease, but specifically hepatitis, also really important to remember that nutrition and frailty are a big part of this. And again, if some of the early studies show that the nutrition, the difference you can make with nutrition is much more than you can make with really any of the medications we have. So moving to liver transplantation, this is the most fun part for me at least. This is for the most severe cases, the ones you can't rescue without transplant. This is really a growing field in the context of alcohol becoming now the leading indication for liver transplantation here in the United States in the past couple of years. This is that pink line here shooting up And this has happened in the context of more alcohol use during the pandemic, and then also uptake of transplant for alcohol-associated hepatitis. So this is the initial experience. This is the Franco-Belgian experience, looking at a population of severe alcohol-associated hepatitis. And you could improve the 6-month outcome from this group, 30% survival to 70 or 80% survival. But importantly, these patients were really highly selected. They had to really not have known that they had liver disease before, had very good support, no coexisting psychiatric disease, and agreed to lifelong abstinence. This all sounds very reasonable. This is, but they excluded over 90% of the people they evaluated because of their psychosocial profiles. So it's really a select group, but when you can do it, it is a life-saving procedure. You probably had heard of the 6-month rule. A lot of us trained during this time when almost all centers in the United States had a 6-month rule requiring at least 6 months of sobriety before you could be considered for a liver transplantation. And this was to let them show that they could remain abstinent for 6 months or longer, and also during that time maybe even have some hepatic recovery. On the flip side, many didn't survive 6 months, and now we know really it's not a great predictor of post-transplant relapse or return to alcohol use. There's not a huge difference between 4 or 6 or 8 months, and there are other better methods of identifying relapse risk. And then a growing recognition that there's a neurobiologic component to alcohol use disorder or addiction, and that relapse may happen, but it's managed after transplant, but we should or are able to manage it. So in that context, we did this survey in 2020 of most of the transplant centers in the United States, and now 70 to 80% of those centers don't require any that have no 6-month rule or have no minimum period of sobriety before a liver transplant. This was 2 years ago, so maybe even more now. If you do transplant, the recognized alcohol relapse rate, which is the undesired outcome, is about 10 to 30%, depending on the center, although only half of that is considered to be hazardous or problematic, return to problematic alcohol use. But that's that red line for frequent binge pattern drinking after transplant, and that's associated with worse outcomes, including mortality and rejection. This is our experience with this patient population. We call it the limited sobriety pathway. Very not strict, but standard criteria, or what's considered standard. First, hepatic decompensation that related to alcohol use, so they can't have known about their liver disease causing this type severity of liver disease. And then a commitment of them to participate in pre and post alcohol rehabilitation. And with this, we've evaluated 160 patients. We're going on 55 transplants now, with 100% survival. So we've had good outcomes. We are the only center actively doing this in Northern California, and also including Northern Nevada. So we do see a lot of these patients and have a pathway to transplant for them. Some caveats that we've, not just our center, but nationally, understanding which patients actually benefit and which may not need transplant is still a kind of a bit of a question mark. Making sure that we have equity and equal access to transplant, and for both patients with alcohol-related liver disease and the remainder of the transplant wait list, because these patients tend to rise to the top, and how that affects the rest of the wait list is also something we need to watch, and how this affects organ donation and public perception is still something we're grappling with. So The treatment for alcohol-associated liver disease, really the key is any cirrhosis or hepatitis. They have to stop drinking and really be committed to not drinking again. Refer them to treatment for their alcohol use disorder. If there is an inflammatory component, prednisolone is what we have. Do remember to check the allele score. And liver transplantation, do consider for select patients who aren't these are sick people, so usually inpatients who may not be able to reach 6 months of sobriety but could benefit from liver transplant. Thank you.
Our next talk is going to be with Dr. Natalie Torok, who is going to be speaking to us about advances in NASH and NAFLD. Dr. Torok is a professor of medicine here at Stanford. Her research focuses on the pathomechanisms and novel therapies related to liver fibrosis. Thank you very much, Dr. Torok.
Thank you very much again, and I'm gonna try to do the impossible to talk about NASH in 15 minutes, and we'll try to stay on time. So first of all, and a lot of you know, and just highlight the problem, the size, the measure of this problem worldwide and in the US. Currently, about a quarter of the population has NAFLD. Many of them under-recognized, not recognized. Worldwide, as you can see, South America, about 30%, Middle East, 31%. And if we move forward to 2030, then you can see that this population, from estimated to be like 83 million currently, will be about 101 million, and in the US, 27 million. So it's a huge number of patients that we are going to see, and we are already seeing. So the current paradigm is, and it's getting refuted as well, that it is a spectrum of disease, starting out with simple steatosis, fat inside the hepatocytes. Then in about 20% of patients with high risk factors, it turns out to be steatohepatitis with inflammatory cells, ballooning, loss of hepatocytes with time. And then it can progress to fibrosis and eventually to cirrhotic stage liver disease. All of this can regress, although this line should be very tiny because we do not see many cirrhotic patients to regress, even on therapies. However, in simple fibrosis F1 to 2, and definitely NASH to steatosis or back to normal is possible. An important thing to recognize is that liver cancer can happen both in cirrhotic patients that we all know and we screen them, but also in patients who don't have full-blown cirrhosis, but just fibrosis F2 to 3, but mostly advanced fibrosis 2 to 3. And these patients are not often screened, and I'll talk about this later. So, and this kind of summarizes that what is the expectations for different fibrosis stages in about 6 years. So the outcomes of NASH are really determined by the presence of fibrosis that can obviously lead to cirrhosis and associated to liver failure and other liver disease-related mortality, portal hypertension, and such. Also very well recognized that these patients have increased, much increased cardiovascular mortality, and often actually this is the cause of death and not as much liver disease. And of course, hepatocellular carcinoma. And just the sheer number of patients that are coming, these numbers are rising sharply, and this is going to be actually number one cause of liver cancer in the near future in this country. A little bit about nomenclature. Many of you probably seen MAFLD or NAFLD, and these present in the literature, and it's not just semantics because MAFLD is metabolic associated fatty liver disease and is defined as the evidence of steatosis with being overweight or obese, having type 2 diabetes, or having evidence of metabolic dysregulation. And this was coined and this was investigated and kind of promoted given the fact that many patients with regular NAFLD, let's say who have also coexisting alcohol drinking, will not be included in that group. So it's a more kind of wider encompassing group who patients with alcohol allowed in this group. And so the debate is out there as to this name change should happen or not. A couple of caveats from this paper are that, number one, the alcohol. We don't understand the natural history of coexisting NASH and alcoholic liver disease, number one. Number two, here, the genetic causes are not well defined. So if somebody has a SNP and has a risk for NASH, this is not well defined in this category. So, but both nomenclature is acceptable. Clinical features suggestive of NASH. So if patient comes to the clinic, has labs, then elevated AST-ALT ratio, as you may know, it's very easy to recognize. Not many other things except alcoholic liver disease can cause that. Elevated APRI, which is the AST platelet ratio index. You can calculate that easily. There's a calculator on the web. And then also high ferritin, we commonly use that because it's an acute phase reactant and it's often elevated even in not having any iron deposition, hemochromatosis, secondary or primary liver disease. So if somebody has a ferritin over 400, has elevated AST, everything else looks fine, I would be worried about that patient. So that's kind of an eyeball test. But then if you look at the history, if they have presence of type 2 diabetes or high HOMA index, again, these are high-risk patients. Discuss metabolic syndrome. You ruled out other etiology of liver disease if you talk about NAFLD, not MAFLD. No significant alcohol use. If this patient is a male, usually the age group when it happens is over 50, or postmenopausal females. So females are protected until menopause, but after that, the incidence is sharply increasing. Ethnicity, Hispanic, Pacific Islander, and different Asian ethnicities are at high risk for NAFLD NASH. And then special patient population, those with polycystic ovary syndrome, growth hormone deficiency, and post-liver transplant. So that's another huge population that is coming up. And there are other special populations as well. I wanted to mention, how do we define who is at risk? So we're going to have millions and millions of patients with simple steatosis, not all going to have NASH or fibrosis. So how we can define that? So one such score is called the SAFE score. That actually consists of age, body mass index, diabetes, platelets, AST, ALT, globulins, and its negative predictive value is pretty good for ruling out severe fibrosis that is F2 or above. And this is due to the previous speaker, Allison, and Dr. Kim, who's in the audience of this paper. So this is, I think, a very useful way to go. Additional things, well, we already mentioned AST-ALT ratio. APRI, we mentioned that. FIB-4 score, although it's not very sensitive. The NAFLD score, again, fibrosis score, you can find a calculator on the website. It was coined by Dr. Paul Angulo. These are easy to access, non-patented scores. And there's also a bunch of other things here and in Europe. You can certainly do it. These are expensive. They have components such as hyaluronan and other byproducts of fibrogenic processes. Again, insurance may or may not approve them, but they are also could be used. And so these are obviously more available. Then if you have a patient, I'm going to show it the next slide, who is, you think, high risk of fibrosis, then you would want to do a transient elastogram. It's available most tertiary care centers, bedside. You can do it in the clinic. And there are more sophisticated approaches such as ARFI, acoustic resonance, force impulse, or two-dimensional elastogram, or MRE, which is more like the higher level MR elastogram. It's a 20-minute procedure, doesn't require IV. It's probably the best estimate of fibrosis because it images the whole liver. It's very well tolerated, and insurance usually approves it. So if you have, a chance, I would do this first and then jump to this. So, but in terms of kind of an algorithm, I'm not going to go through in detail, there's no time, but the bottom line, what we already discussed, that you get either a FIB4 or some other non-invasive test, low risk, currently lifestyle changes, and I'll go into that as to what else you can do in terms of medical management. For intermediate risk, best to refer them to a referral center, to GI or hepatology, fibroscan, different versions of elastogram. These groups, that if you have, I would consider liver biopsy in these patients if you think there is a coexistent liver disease, something just doesn't make sense. Let's say they have a huge increase in ALK phos, something else that just doesn't make sense. But other than that, if it's straightforward, just for the sake of fibrosis, I probably wouldn't do it. Cost, potential risk, and so on. And then what else would you do differently, whether or not they have fibrosis? You cannot offer them actually currently any approved agent that is an antifibrotic. So, so let's move on. Oops, because I want to talk about lean NASH. Lean NASH is a more recently recognized entity. These patients are not obese, so they actually would not fit the NAFLD criteria too well. But it seems that 40% of the global NAFLD population is lean. And it seems that these patients have a healthier metabolic profile, lower disease progression, but their cardiovascular disease rate and malignancies compared to obese NAFLD. So it's a very important patient group to recognize. And you do pretty much the same as with regular patients once you recognize they have abnormal liver enzymes, and really there's nothing else to explain this by. You really need to do an aggressive cardiometabolic risk factor assessment in this population, modify that, send them to cardiology if you have findings, and then everything else is pretty much the same as with the regular NAFLD group. Just a few words of NASH and alcohol. As I mentioned, no good natural prospective studies yet, but the synergistic effects on lipid metabolism and alcohol toxicity are well recognized. This genetic variant is strongly associated with both NAFLD and alcohol-associated liver disease, and it's highly prevalent in Hispanic populations and Hmongs and some other populations. These patients have more rapid fibrosis, especially those post-bariatric surgery. So you have to really closely monitor those patients and make sure they don't drink. Screening high-risk populations, and it's very interesting that in Europe, different societies recommend screening for NAFLD, even just obesity, metabolic syndrome, and type 2 diabetes, so they don't have to have cirrhosis. And screening, meaning screening for liver cancer. APSL also recommends screening high-risk population, those with obesity and diabetes. In the US, we only have recommendations from ADA, the Diabetes Association, who recommends screening NASH patients with advanced fibrosis. But yet, we don't have ASLD recommendation, and the reason is that it's not deemed to be cost-effective, or we don't know the natural history and cost of screening pre-cirrhotic patients. We also have to screen for comorbidities. As I mentioned, cardiovascular risk is really high in these patients, and it's our job to kind of go after that and have coronary CT and other measures to kind of have a primary assessment. Statins are actually used for NASH as well. Aspirin, tight control of glycemic status. I usually send these patients to endocrinology because sometimes NAFLD, type 2 diabetes, management is very complex, and sometimes they do not respond, or they get more and more and more insulin, and actually it's not helping. So best if endocrinology sees them. Sarcopenia is a really under-recognized problem in these patients. We can't see that, but if you perform a study where you look at L3 muscle mass, then you can see it, and presence of sarcopenia is also associated with advanced fibrosis, so this needs attention. Cancer screening, as it is, screening for liver cancer in patients every 6 months in those who have cirrhosis, but no specific guidelines for non-cirrhotic patients, kind of alluded that on the previous slide. Obese patients are at higher risk for colon and breast cancer, so as per guidelines, we have to push them to be screened and remind them during the appointment. Treatment, very quickly because time is up. FXR agonist, obeticholic acid, there's been a lot of publicity and a lot of papers about it. The bottom line, it does improve liver enzymes in quarter of patient NASH resolution, but there was no effect on fibrosis in this earlier trial. It does cause pruritus, at least the obeticholic acid, but there are newer FXR agonists that this effect may not be as pronounced. So if, however, you kind of stratify and select patients out of this huge population that was tested, there could be dynamic changes seen in non-invasive tests in the histologic responders and from non-responders. So it may have actually an anti-fibrogenic effect in a portion of the population, and so this study is actually looking at that. But it's not in the mainstream yet, given the side effects. However, what's in mainstream, both the GLP agonist and SGLT2 inhibitors that I'm sure many of you are using, these are FDA approved also for obesity, and they're also good for NASH. And in studies, there was a significant reduction in AST, ALT level, weight, HbA1c. These are usually well tolerated other than nausea and bloating in some patients, but this is dose dependent, and you can actually kind of adjust that. As to what they do to fibrosis, again, the jury is out there yet. We don't know, but it's well tolerated. Actually, there are ongoing trials in cirrhotic patients, and we have one of those here at Stanford. SGLT inhibitors, similarly, improvement in liver steatosis, enzyme, weight loss, using caution with people who have genitourinary issues, especially like elderly male patients. So in summary, we still advertise lifestyle modifications so that there is no change. Statin, very underused, and we are really, really encouraging using statins because even though with the black box warning, there's no huge evidence that NASH patients are more sensitive to statins in terms of delayed drug-induced reaction. So I have not seen one yet. We just have to measure the liver enzymes as we start the statin. Bariatric surgery, vitamin E, pioglitazone, it's used in Europe, not as much here because of weight gain. Again, as I mentioned, liraglutide and associated drugs are helpful, and so are SGLT2 inhibitors. And again, in cirrhosis, there's not much out there yet, but maybe these will become useful combined with other medications, and really important to screen for varices and just do the usual workup for portal hypertension. And I think that's all I had. Thank you.
I'm going to introduce Dr. Peace Dike. She's one of our colleagues in the Division of Pediatric Gastroenterology, where she's a clinical assistant professor of medicine. She's going to talk to us now about cholestatic liver diseases, therapies that are on the horizon. Dr. Dike?
Thank you all so much for having me. So again, my name is Dike, and I am a pediatric transplant hepatologist. And so I'll be talking about cholestatic liver disease therapies. A lot of these therapies may be known to a lot of people in the room, especially on the adult side. A lot of my talk will be focused on the pediatrics side and a lot of the advances that we're making on that front. So in pediatrics, just looking at indications for liver transplantation, so nearly 50% of children that we have, at least that was recorded in 2020 from the Society of Liver Transplantation, 50% of the cases are due to cholestatic liver diseases. So biliary atresia, Alagille, PFIX, which is known to all of us, ductal plate abnormalities, PSC, which has crossover to the adult side, bile acid synthesis defects and metabolic diseases are common indications for transplantation on our side. And so for the rest of the talk, I'll talk a little bit more about some of these predominant clinical diseases that therapies have been looked at. So the management of cholestatic liver disease ultimately has been really focused on mostly supportive care for complications from cholestasis. So malnutrition is a big thing for our patients, especially on the pediatric side, and how to manage complications that arise from fat-soluble vitamin deficiencies. Pruritus is a big thing as well, especially for our patients who have Alagille or PFIX, and especially in Alagille can sometimes be a primary indication to move forward with liver transplant and definitely affects the quality of life for a lot of our patients. And then, of course, some of the complications that happen as a consequence of portal hypertension, which we all know range from varicose hemorrhage, ascites, SBP, hepatopulmonary, and all of those other complications. So because of a lot of our therapies are focused on supportive care, ultimately the majority of our patients go on to require liver transplantation as a mainstay way to deal with their cholestatic liver disease. So there's been really, as far as on the pediatric side, a lack of therapies that really prevent the progression of liver disease. So as we know, with cholestasis, it's due to impaired bile flow that results in bile retention and accumulation of bile contents, and specifically focusing in on the bile acids. And really the way in which bile acids induce hepatocellular damage is through altered immune responses with induction of pro-inflammatory mediators, increased fibrogenesis, and then there's some apoptotic and autophagy mechanisms. And those are the things that we'll focus on when we're talking about the bile acid effects and how we treat cholestasis. So the therapies and the newer therapies have been really focused on how do we disrupt intrahepatic circulation of bile acids by not only reducing the total bile acid pool, but really reducing those toxic bile acids, especially those hydrophobic bile acids like LCA and some of those other secondary bile acids, as well as altering the expression of bile acid transporters, decreasing the production through synthesis, and then one of the areas of interest that I have is how we regulate bile acid receptor-mediated signaling in the liver. So just as a quick recap for all of us, we know this quite well about bile acid synthesis and metabolism. So it begins in the hepatocyte. Bile acids are synthesized from our cholesterol precursor via two different pathways, with the rate-limiting step being really that CYP7A1. And that's where we form our primary bile acids. The transport out of the hepatocyte is mediated mainly through the bile salt exporter pump, or BSEP, and that exports these bile acids through the biliary tree and out into the ileum. And then we know about 90% of bile acids are reabsorbed, with only about 3 to 5% actually being excreted in the the feces. And so the predominant mechanism by which bile acids are reabsorbed are in the terminal ileum, and it's by this apical sodium-dependent bile acid salt transporter, which has been a target of many of the therapies that have to do with cholestatic liver disease. There's also other transporters that are really important that are on the basolateral membrane of the ileum, as well as on the apical side of the hepatocyte with reuptake, but I won't focus on any of those in this talk. And then again, as I said before, there's a lot of talk, and some of the other speakers have already talked about these bile acid receptors and receptor-mediated signaling, and specifically with FXR, or the farnesoid X receptor, which is one of the primary nuclear bile acid receptors. There's others that we know, PXR, LXR, all of those others, but FXR is the main one. And then TGR5 is a very interesting one. I won't talk a lot about that one, but that one also has probably very important implications in cholestasis, as well as some of the complications of cholestasis, like pruritus, because TGR5 is also found on other cells like neurons, and they mediate itch. So one of the challenges, before I get into some of the studies, one of the challenges in developing therapies is what's going to be our endpoint, especially for rare diseases where the sample sizes are very small. So usually the endpoints that are in the literature have to do with alkaline phosphatase, but that can vary and sometimes fluctuate naturally with diseases. And some of these other primary endpoints that we use, again, we're dealing with very small sample sizes, so it's difficult. And so for a lot of these, I think what is most important when we're looking at the endpoints of these disease and determining, or these therapies, and determining what's efficacious for our patients is probably combining these endpoints to determine their efficacy. But some of these other ones that we can look at that have been talked about too as well include patient-reported outcomes, which we use quite a bit with our patients when we're talking about pruritus scores. Liver stiffness is a great one as a non-invasive means to determine fibrosis or scarring, and then other exploratory biomarkers of inflammation, as well as fibrosis. And so just a little bit about some therapies that are already being used or talked about. So therapies that really target intrahepatic circulation and really to decrease that toxic bile acid pool. So commonly ursodiol has been used. There's this new formulation, nor-ursodeoxycholic acid, which is a little bit more of a potent form, and it has additional mechanisms to treat cholestasis by really decreasing, again, those hydrophobic bile acids that tend to be more toxic to the hepatocyte, by promoting chlorosis through secretion of chloride and bicarb, and also altering the expression of some of these bile acid transporters, as well as its effects on the immune system and ER stress. And so some studies that have already preliminarily looked at it. So there's some mouse models that have looked, mouse models of PSC and PFIC that have looked at it, that maybe nor-ursodeoxycholic acid may be effective in preventing liver disease progression. Cystic fibrosis, another cholestatic disease. So in knockout mice, it may help to increase biliary bicarb and fluid secretion, which is really important in a lot of our patients who develop cholestasis due to sludging in their biliary system. There's also other mouse models that have looked at nor-ursodeoxycholic acid in other ways in which it may affect disease progression. And then looking at intrahepatic circulation and actually decreasing the total bile acid pool. So there's a class of PPAR receptors. And so I know there was mention about PPAR receptors. There's different subtypes, but specifically when we're thinking about cholestasis and how do we reduce bile acids and bile acid-induced injury, PPAR alpha has been looked at because it does mediate bile acid homeostasis and downregulates synthesis. So there's been some observational studies that have looked at this, and there's one international study that's looked at combining the fenofibrate with ursodeoxycholic acid, and the endpoints, again, that they used was really looking at alkaline phosphatase, and they showed in those patients, especially patients who didn't initially respond to ursodeoxycholic acid, that they did have a decrease in their ALP. So I'm going to move a little quicker. And so looking, again, how do we decrease the total bile acid pool? So there's the ASBT inhibitors, which I think we're all familiar with, which most of the studies have really looked at a primary endpoint for pruritus and decreasing the serum bile acids. Again, there's PFIC, Alagil, and PSC. In a few of the studies that have looked at maralixabat over there on the left, they've looked at PFIC specifically, and in those patients that responded, they had significant reductions in their bile acid, serum bile acids and pruritus scores, but also in their height and weight. And more importantly, those responders remained liver transplant free after or greater than 5 years, which is an important endpoint to look at. Secondarily, looking at odevixibat and PFIC as well, another double-blind study that looked at pruritus as an endpoint. And as you can see here, at varying doses, either at 40 or 20 micrograms per kilo, the patients compared to placebo had improvement in their endpoints. I'll go through this a little bit quicker so we can get to this. So looking at modulation of bile acid receptor signaling, a lot of the studies that we've looked at so far have looked really at PFIX, PSC. I know there's studies in PBC where obeticholic acid was used. I just wanted to highlight, too, that there is an INT 767, which is an FXR agonist, but also a TGR5 agonist that has shown some mouse model improvement in fibrosis. But there's no human studies yet that I know of that are looking at that. And then as far as the FXR agonist that I wanted to look at specifically was obeticholic acid. And in this study, again, it was in patients with PSC, so adult patients with PSC, using a primary endpoint of alkaline phosphatase at 24 weeks. They had other secondary endpoints which they did not meet, but at least you can see visually in the box and in the triangle that they were able to meet their endpoint, and that the endpoint of improved alkaline phosphatase was actually sustained. And it was most significant for that higher dose, the titrated up dose 5 to 10. Again, in that one, they weren't able to meet some of their secondary endpoints, which have to do with enhanced fibrosis and markers of non-invasive markers of fibrosis. So this study also looking at cilofexor looked at a dose, 2 different doses versus placebo, also PSC, with similar primary endpoints. Safety was a big one because of some prior studies of FXR agonist. And then they had some secondary endpoints, again, to look at non-invasive measures of fibrosis, as well as activity, its potent activity of FXR. And so with this study, you can see that with both studies, but mostly in a dose-dependent fashion, that cilofexor was very effective in decreasing alkaline phosphatase. And although there was not a statistically significant improvement in fibrosis, non-invasive measures of fibrosis, there was a trend in this study towards decrease in some of those non-invasive biomarkers of collagen deposition and fibrosis. And so I listed out just a few other mechanisms by which bile acids can affect, which is fibrosis, again, immunoregulatory ways with increasing inflammation. And so some of these other therapies have looked at that and how targeting them may affect the overall disease progression for patients. So the first one, Sinezivarok, there's a clinical trial that's looked at this that's shown some variable results, but essentially it's targeted towards monocytes and the activation of hepatic stellate cells to see if inhibiting that would change the course in patients. There's also been different analogs, and here I listed out a few other things that have they've looked at for that. And so I just wanted to end on really quickly again on cholestatic liver disease. So I'm really interested in biliary atresia. That's the largest indication for liver transplant in the pediatric population. And so really in the last 50-ish, 60 years since the Kasai became a standard treatment, there really hasn't been much else but Kasai or transplant for these patients. So this study just recently came out in 2023 that's looking at bile acids as a biomarker in biliary atresia for patients who received a Kasai portoenterostomy. As many of you all know, a lot of patients who clear their bilirubin at 3 months post-Kasai still may go on to have progressive liver disease. So there's still some question about what is really driving that. But what we see in this study is that serum bile acids can be used as a prognostic biomarker. And actually, this study showed that at 6 months, serum bile acids greater than 40 predicted those patients who would go on to have increased fibrosis and complications from portal hypertension. So because of that, there are studies at this point where we're looking at how do we mediate bile acids in biliary atresia. So our center is a part of EMBARK now. And so we're looking at marabixalat and its response to patients post-Kasai. So hopefully there will be interesting things coming out in the future for that. Thank y'all.
Our next speaker is Dr. Paul Kwong, who's a professor of medicine here at Stanford and is the director of hepatology. He's going to be speaking to us about hepatitis B, moving towards a cure. Thank you, Dr. Kwong.
Hi, good afternoon. Thanks for coming and visiting with us. This is going to be a very nice 3-day event, and I really appreciate the invitation to speak. I'm Paul Kwong. I'm one of the liver doctors. And I'm going to spend a few minutes talking about hepatitis B, how we approach it now, and then just a glimpse of the future, which is this so-called functional cure, which we'll go into in some detail. Disclosures. So all of you know that hepatitis B is, if you will, the most common prevalent virus worldwide that affects the liver. Depending on which estimate you look at, there are greater than 250 million people who are infected. 2 billion people have been exposed to hepatitis B. The majority, as you can see, is in Africa and Asia, but certainly we have our cases in the Americas, North, South America. It's about 7 million individuals. In the U.S., it's not entirely clear the exact population, but ranges are anywhere from 1 to 2 million people have chronic hepatitis B, and many are not yet diagnosed. It is a very infectious virus, more infectious than HIV. And again, as I said, particularly in the Bay Area, you have to particularly be aware of this. There's very high prevalence in Vietnamese, Chinese, Korean Americans, and many of these individuals aren't diagnosed, some of it due to stigma, some of it due to lack of access to health care. And again, we do have therapies that can really improve the outcomes for hepatitis B. Pardon me, there we go. Other important thing, hepatitis B is the second amongst the most important carcinogens after tobacco. 70% of hepatitis B related deaths are due to liver cancer. And hepatitis B is the dominant etiology of liver cancer worldwide. So these are all important. It's in the afternoon, you've had lunch, so we're not going to go through complicated pathways. But what we are going to do is just show you here that the hepatitis B enters here through the sodium torcoylate receptor here, uncoats in the nucleus to the cccDNA, and then our drugs work right here, and we use these reverse transcriptase inhibitors that really are very effective at knocking down the hepatitis B DNA levels. However, they are very ineffective in clearing the reservoir of hepatitis B here called cccDNA in the nucleus. And this is why once you have hepatitis B, it is very hard to clear it. And some people argue you're never cured of hepatitis B once you have the infection, although I'm going to show you some very promising data that we are at least getting somewhat closer to what's called this elusive functional cure. In the clinic, what do we order? Well, we look, to screen for hepatitis B, we want to screen with a surface antigen. We also look for a core IgG and a surface antibody. But in general, the surface antigen confirms that you are actively infected. The E antigen, there are not as many, probably 10-15% of the people in the US will probably have E antigen positivity. It means you're highly infective. Those of you who practiced 40 years ago, 30 years ago, know that they used to use E antigen to distinguish which surgeons could operate and which surgeons could not, because E antigen was a marker of high HBV DNA. The core IgM we use for acute infection. Surface antibody means that you are immune, and then the core IgG means you have been exposed. And again, the CDC just came out with a very nice, essentially universal screening. They did away with risk-based screening, which was great, because risk-based screening really doesn't work in any of these diseases. And so it's the core antibody, the surface antibody, and the surface antigen that we should be screening individuals for hepatitis B. So there is also, you can order a quantitative surface antigen. It doesn't have a role yet, it will have one. There are a few labs that do this. At Stanford, if you practice here, we have this hepatitis B surface antigen index, which isn't quite the same as the commercial assays that are available, but you can quantify the surface antigen, and the quantification of surface antigen actually helps distinguish these inactive carriers. With our current guidances, there are these so-called gray zone cases, and the higher the surface antigen, the higher the risk of liver cancer. The higher the surface antigen, also the less likely you're going to be to respond to our only approved immunomodulatory therapy, and that's PEG interferon. And it also, if you treat and with nucleoside analog, or if you just see a patient, if you have a low surface antigen, some of us do incorporate it into our practice, not yet ready for prime time, but it's out there. And it actually, I think, is useful. And I'm going to show you some of the applications that people have used to help manage patients with hepatitis B. We do order an HBV DNA. And remember this, hepatitis B is a carcinogen. And so, as we have shown you, it causes liver cancer. And this is a very famous study that came out of Taiwan, the REVEAL study. And what it shows is this biologic gradient. So you have here cumulative incidence of HCC here, cumulative relative risk of hepatocellular carcinoma here. And you can see here with higher levels of HBV DNA, your risks of cancer start going up considerably, particularly above 10,000 copies here. This is where the risk really starts going up here. And so we often will treat older people who have viremia, even if the AST and ALT aren't normal or are normal, because some of these individuals, we think the risk of the high viremia just increases your risk of hepatocellular cancer. And when we talk about treatment, I would just like to point out we have actually good tools to suppress the virus. Historically, we've never not suppressed a virus to undetected. Those of you who've been around know HIV. We used to say, don't treat HIV, right? Just let it, and then you just intervene. We now know that we treat HIV right away. If we had a therapy now that cleared surface antigen in everybody, we would be treating this like hepatitis C. There is no question. And so I'm going to show you that we might be getting very close to that. So the goals of therapy, again, when we give a medicine for hepatitis B, you want to improve the liver histology. You want to decline or drive the hepatitis B surface, the hepatitis HBV DNA down to undetectable. You want the ALT to normalize, and you want seroconversion. You don't get all of this, but this is what we want. You can usually, if you treat with a nucleoside analog, you'll get these three most of the time. You can lose E antigen. The loss of surface antigen is more challenging, as I'm going to show you. So who are the candidates that we treat for hepatitis B? Well, they're shown here, and I have the guidances here. And again, these are societal guidances. So you can see here they're based on the viral level, and also whether or not the ALT is above the upper limit of normal. And you can see here that we have Asian, European, there's a US algorithm, and then we have the ASLD guidance here. And what you can see here is that when the HBV DNA is above 2,000 or 20,000 international units, and the ALT is either 2 times the upper limit of normal for the ASLD, US algorithm, it's for males it's 30, females 19, EASL uses 40. But you can see here when you have virus plus an ALT level, then generally you treat these individuals. ASLD guidance over time, since we're in the US, has actually evolved, and so that sometimes you have these people in the gray zone, those that are 1 to 2 times the upper limit of normal. If you've ruled out other causes, you can still treat these individuals if you think hepatitis B is driving this. And I think with each iteration of practice guidance, the thresholds are going lower and lower and lower to treat hepatitis B because the suppressive therapies are really quite good. And again, this just shows here that, again, we're now adding different areas. If you have cirrhosis, then if you have a low level of viremia, you still should be treated. If you're decompensated, doesn't really matter if if the DNA is detected or not, you treat. And again, there are selected individuals that we can treat as well. Even those with normal ALT and elevated HBV DNA, if you have significant inflammation by a FibroScan or liver biopsy and are over the age of 40. Again, just reflecting that hepatitis B is a carcinogen, and it's important that we reduce the rates of hepatocellular carcinoma. If you're not going to treat these individuals or the patient doesn't want to be treated, the first time you meet them, we usually like to get a liver panel every 3 months the first year just to make sure the ALT and AST is not bumping up and down. Right? And so sometimes you see them on this day, it might be 39, but you might get one 3 months later, it's 56, et cetera. And so you just want to know that so that when you bring them back, you can say, hey, it was okay on this day, but unfortunately, you seem to have this intermittent hepatitis, and we need to revisit treating. HBV DNA, again, similarly, just depending, if it's very, very low, you just probably need to do it twice a year. But again, if you're borderline, more frequently, especially if you're contemplating treatment. And again, looking at the E antigen should be done on an annual basis. The surface antigen at least annually. And then if you're on treatment, obviously you should do it once a year as well to see if you clear surface antigen. And we do want you to screen individuals for hepatocellular carcinoma. So here are the ASLD practice guidance recommendations. So everyone with hepatitis B with cirrhosis, family history, Asian or African American men greater than the age of 40, Asian women greater than the age of 50, co-infected with HDV. I will tell you, many of us screen more liberally than this. I'm actually getting an ultrasound starting around age 30 because I just seems to me, if you're age 18, you meet somebody, it just, and something that says oncogenic, you don't say, hi, we'll see you back at age 40, right? And we'll do the next ultrasound. And we're going to just not look for the next 32 years. And so I typically start screening earlier than that. It is something, though, that you have to be cognizant of, and I think we need better guidance here because, you know, there are people who dwell on this. Oh, my God, am I going to get a liver cancer? So you have to be careful. So when they're younger, I like to get an ultrasound once a year. I recognize that's not in the practice guidance, but I don't just start screening at age 40. And some people just start screening every 6 months, in their 20s. And you would just find there's a large variance in everyone's practice. Here we go, the approved therapies here. We use the oral therapies, tenofovir disoproxil, tenofovir alafenamide, and entecavir. There's a cytokine we use, peginterferon alpha. I haven't used it in the last 5 to 6 years, and it'd be fascinating to see who has used it. We just don't use it very often because our nucleotide analogs are very, very effective. There are alternatives we rarely, if ever, use. We might have someone turn up occasionally on one of these medicines, but not for several years now. And so they're very, very highly effective, both in compensated disease as well as decompensated cirrhosis. And you can see here that with decompensated cirrhosis right now, preferred are tenofovir, disoproxil, and entecavir. But you certainly can use TAF and entecavir in individuals who have renal dysfunction. The cirrhosis, this is a very famous liver biopsy from Ian Wanless, just showing this was a cirrhotic liver, and I think I can convince all of you these are nodules, right? And so this person got lamivudine. Here's the first, sorry, I'm not very good at this. Here's the first biopsy here showing the nodules, And then you can see here, this was with lamivudine, one of our first generation nucleoside analogs. You can see here the cirrhosis is cleared up. And again, many studies have now confirmed this. On therapy, how do you monitor? The first year, every 12 weeks, not because our first-line therapies are ineffective. They all work. It's to make sure they actually take the medicine. And if the viral level doesn't go down 99 times out of 100, it's because they're not taking the medicine, not because you've developed resistance. There really hasn't been resistance to tenofovir described. This is tenofovir disoproxil, tenofovir alafenamide, and entecavir resistance. The first few years there was a very low percent, but the resistance with entecavir is also extremely low as well. You do need to look at the renal function on tenofovir disoproxil. That's why we like tenofovir alafenamide a bit better than entecavir. There is some mild reduction in EGFR, and we're not really using adefovir anymore. But you should be looking at the renal function in these individuals. So once we start therapy, so what are our endpoints? So we've really just used suppression of HBV DNA. But again, the title of this talk was aiming for functional cure. So what does that mean? Well, so you start therapy here, you drive the HBV DNA to undetectable. That's great, and that's what we do in the clinic. What we really want to do is clear surface antigen, and this is what we mean by functional cure. What would you really like to do? You'd like to get rid of this incorporated CCC DNA that I showed you on the first diagram of the hepatitis B life cycle that's in the nucleus. And actually, there was just a paper in the last few weeks where there was a CCC DNA inhibitor. So it's going to be interesting to see if we can do this. But we really don't do this very well. We do want to do this because it reduces long-term NA toxicity. You reduce costs with lifelong therapy, avoid risks of flare, reduce reactivation, and you improve clinical outcomes. So with our current therapies, how do we do this? Well, defined duration, 12 months. Both e-antigen, for PEG and interferon, it's just 12 months, but none of us really are using this much anymore. Nucleotide analogs, e-antigen positive, seroconversion, that means clear e-antigen. We used to say consolidate for a year or two and then stop, but most of us now just keep treating until the surface antigen clears. Because if you stop, the virus level most commonly does come back. And I would say the vast majority, we can discuss this a little bit later, won't stop with e-seroconversion. If you're e-antigen negative, it's indefinite, and that means that we just go until surface antigen loss, which only occurs a few % per year. You can stop therapy, but I'm going to show you this. It's not ready for prime time yet. And this just shows you in the surface antigen loss rates are extremely low. With interferon, they're a little bit higher. These are anywhere from 2 to 5 years, but you can see here, they're all under 10% here for the nukes, and sometimes much less than that. In an e-antigen negative, it's really low and disappointing. And that's the majority of people with hepatitis B. You can discontinue the nukes, and this is a series of reports where people are trying to do this, and you do get some surface antigen loss rates. There's also a hepatitis B flare rate, but you can see in selected individuals, particularly if you're European, you seem to do better than Asians do with this strategy. This is possible. There was a large North American cohort study that tried this, and the rate was 4% when you stop therapy. New targets, there's lots of them. The one that has been most promising are these inhibition of protein translation, and this is inhibiting right here with silencing the RNA. This can be a silencing siRNA or an oligonucleotide that interferes with messenger RNA, but there's lots of different mechanisms of action that people are now pursuing, and this was in the New England Journal a few months ago. And this was this naked oligonucleotide, antisense oligonucleotide called bepirovirsen, and this actually is given weekly, subcutaneous injection, and you can see here that what they got after 24 weeks of this weekly injection, 12% of people that receiving nucleotide analogs were surface antigen negative and were sustained 14% if you were not on a nucleotide. And so this is the best data we have. It's early days, but it reminds you of the first data we had with combinations of direct-acting antiviral agents, where we were able to, with the first BMS portfolio, Bristol-Myers Squibb, declatosphere, they were able to get some sustained responses. Early days, but this is our foot in the door. And this is going to be combined, by the way, in this particular study, you did much better if you had a low surface antigen level as well, less than 3,000 international units. but it's our foot in the door, so it's coming. Lots of trials coming, by the way. I mean, just combining direct-acting and immunomodulatory therapies. So, getting to functional cure. So, preliminary data is encouraging, but it's still early days. Know your patient's hepatitis B status and know when to start therapy, which basically means right now DNA greater than 20,000 for e antigen positive, 2,000 for e antigen negative, plus an elevated ALT, or significant disease on elastography or biopsy. We rarely biopsy hepatitis B patients. When you start a therapy with a nucleoside analog, the functional cure rates are going to be extremely low, but the viral suppression rates are excellent. And there are novel agents that are entering trials now, both immunomodulatory, neutralizing, as well as direct-acting against various mechanisms in the hepatitis B life cycle. And then I've already showed you this bepirovirsen antisense oligonucleotide degrades the HBV RNA, and this one is actually shown a potential increase in functional cure rate. Screen your appropriate individuals for HCC. It's still the leading cause worldwide. And remember, vaccinate also, okay, because we have an effective vaccine for this. Recent ACIP guidance was vaccinate everyone up to 59, and everyone really should be able to get the hepatitis B vaccine. I apologize, I know that was a whirlwind, but that's a glimpse of what's coming. Thanks so much.
Our next talk is going to be with Dr. Tara Ghaziani. She's a clinical assistant professor of medicine here at Stanford and directs the Liver Mass Clinic. She's going to be speaking to us about the role of liver transplantation for cholangiocarcinoma. Thank you, Dr. Ghaziani.
Thank you, Deepti. Good afternoon. Well, Dr. Ko is such a great speaker. It wasn't fair to put my talk after his. I'm Tara Ghaziani. I'm a transplant hepatologist who have interest in transplant oncology. No disclosure. So why are we talking about liver transplantation for cholangiocarcinoma, which is such a disease with such a high mortality rate? Basically, the 5-year survival for this disease is only less than 20%. The preferred treatment choice for cholangiocarcinoma in tumors that are confined to the liver without any extrahepatic metastases is surgical resection. But the problem is majority of the patients are technically unresectable. So the question here is, if we can't do a hepatic resection, can we do a total hepatectomy and do a liver transplant for these patients? That is in line with the fact that the field of transplant oncology is really expanding in the past few years and trying really to push the envelope and considering more indications of transplantation for liver tumors, different types. But if we are considering new indications for transplant, we do need to have a benchmark. The benchmark for an acceptable indication for liver transplant since 1990s, based on the transplant societies, is that patients should be offered transplantation if we think that the 5-year survival post-transplant is going to be about 50%. Obviously, they should have a reasonable quality of life. So I'll be just reviewing quickly over the epidemiology of cholangiocarcinoma, talking about the types of cholangio and standard of treatment, plus the facts around the state of transplantation for these patients. The cholangiocarcinoma is the second most common primary liver cancer after hepatocellular carcinoma or HCC, accounting for 15% of all primary liver cancers. The reason for such a high mortality for this cancer is that it has a silent presentation. Majority of patients are diagnosed incidentally and with advanced cancer. They have no symptoms. Has a very aggressive nature, biology, and response to chemotherapy is rather low in cholangiocarcinoma comparing to some other solid tumors such as colon cancer. In contrast to HCC, which is diagnosed based on the radiographic features according to the LIRADS criteria that our next speaker will go over the details, which has like over 95% accuracy in diagnosis. But for cholangiocarcinoma, non-invasive approaches such as imaging is not that accurate. That's why we need a biopsy to confirm diagnosis. In contrast to HCC, cholangio usually develops in non-cirrhotic liver. What about the risk factors? Well, cholangio is associated with chronic inflammation of the biliary epithelium and bile stasis, similar to what we see in primary sclerosing cholangitis and Caroli disease, choledochal cyst. But majority of cholangio cases are really sporadic without any identifiable risk factor. There's another entity, it's a rare tumor, it's called mixed HCC cholangio, has a very aggressive behavior, poor prognosis, and basically the tumors share the features of both intrahepatic cholangio and HCC. So based on the anatomical site of the tumor, cholangiocarcinoma is classified into 3 categories. The most common one is the hilar or I don't know if this is working. Sorry. So perihilar cholangiocarcinoma or PCCA, and there's a distal cholangiocarcinoma or DCCA, which tumor basically is arising in the CBD between the ampulla and the origin of the cystic duct. And the last one is the intrahepatic one, that the tumor is originating in the above the second order bile duct into the parenchyma. Why is it important? Why are we classifying this tumor? Because these 3 categories, they have different biology, they have different risk factors, the clinical presentation is different, same as management and prognosis. So basically, that just adds to the complexity of managing this tumor. Surgical resection, so this is as I mentioned, is the preferred choice of treatment, but most patients are unresectable either due to tumor location, having a multifocal disease, or having extrahepatic metastases, or even underlying cirrhosis or portal hypertension makes them unresectable. If the surgery is done with intent of having a margin negative or R0 resection, that can potentially provide a cure. But the post-resection recurrences is very high. It can be up to 70%. And most of these tumors recur within the liver, suggesting that we're probably missing a lot of microfoci of intrahepatic metastases at the time of resection. But 5-year overall survival is ranging from 15 to 45% post-resection. The reason I said it's potentially curative because the best case scenario gives you that 45% overall survival. And there are some patients that are originally unresectable, but they receive chemotherapy, eventually the tumor shrinks and they become resectable. This slide just shows you the overall state of transplantation for cholangiocarcinoma. For perihilar cholangio or PCCA, this is currently an approved indication for liver transplant, especially in the US. But these patients require a very strict selection process. They have to go through the neoadjuvant chemo, radiation, and they require an laparoscopic staging before liver transplant. For the intrahepatic cholangio, or ICCA, things are really not that straightforward. Because ICCA historically been a contraindication for liver transplant, and because this disease has a very poor outcome. But as I will be showing you in the next few slides, the data shows that with when improved patient selection and adding neoadjuvant therapy, we're actually seeing good survival post-liver transplant for even this type of cancer. But at the moment, there is no standard protocol for treatment of ICCA using liver transplant. First, we're going to just show a couple of slides about the current outcome of liver transplant for PCCA in the US, perihilar cholangio. So early studies, single-center reports showed excellent outcome for liver transplant for PCCA. And eventually, in 2012, we have data from 12 large volume centers in the US that showed patients with early stage perihilar cholangiocarcinoma unresectable who received neoadjuvant chemo and radiation, and they had a liver transplant. They actually had a good outcome with up to 65% recurrence-free survival. And therefore, since 2009, UNOS offers or grants a standard MELD exception point for patients who are listed with perihilar cholangiocarcinoma, and they receive priority on the list. A step forward even, in addition to that, there is a clinical trial now is looking at this question that whether transplant is actually superior to resection, even in resectable early stage perihilar cholangiocarcinoma. The reason is that, as I mentioned, with R0 resection, you may get a 5-year survival close to 40%, but retrospective studies comparing transplant versus resection in patients with almost similar profile of early stage perihilar cholangio, we see that the survival is much better with liver transplant. But obviously, we need the prospective trial results to see if they can change the policy eventually. In order for a patient to receive a liver transplant for early stage perihilar cholangio in the US, there are 2 steps. First, they have to go through a unified diagnostic process. Based on the UNOS policy, all we need is presence of a malignant appearing stricture on the cholangiogram, plus one of the followings: having a biopsy or cytology brushing from the ERCP to show that the malignancy, or a CA99/100 in the absence of cholangitis, and an abnormal or positive FISH test on cytology, or a hilar mass, which is less than 3 centimeter in radial diameter, not the longitudinal along the bile duct. It's important to know that patients should not have a transperitoneal biopsy, including percutaneous biopsy, laparoscopic biopsy, or even EUS-guided biopsy of the tumor, and that's because of the high risk of tumor seeding. The only acceptable way of getting tissue is through ERCP. Once the diagnosis is confirmed, what needs to be submitted to UNOS for approval is that we have to document that the tumor is unresectable, either technically or because of their liver disease. We need to show there is no intrahepatic or extrahepatic metastases using imaging. It is preferred to have an EUS-guided biopsy of the portal lymph node even before starting chemo, just to show at baseline we don't have any extrahepatic metastases. Patients go through neoadjuvant chemo radiation, and eventually they get a laparoscopic staging again to rule out any extrahepatic disease, and that can be done just before the transplant. So that basically was a clear, plan, picture, or protocol for getting someone with early stage perihilar cholangio transplanted. But things are still controversial and debated in terms of transplantation for intrahepatic cholangiocarcinoma. The concept of even thinking that liver transplant is a viable option for early stage intrahepatic cholangio came from this study. It's a very nice study from Gonzalez Saporchin who studied European patients. This is from 2016. They looked at the explant data on patients who were transplanted for a presumed HCC, but on the explant they found cholangiocarcinoma. And they looked at different characteristics of the tumors. Eventually they found out that patients with a very small cholangio, less than 2 centimeter, they actually had a very good 5-year survival, up to 65%, and the recurrence rate was really low, 18% at 5 years. So this really opened up the field for other centers to look at the same question. And then French centers basically challenged the size criteria. They wanted to see, okay, what if we have a tumor larger than 2 centimeter? What about tumors up to 5? They also looked at the explant data, and they also saw a good result with 75% recurrence-free survival for incidentally found ICC up to 5 cm. Interestingly, other centers were unable to reproduce the same good outcome if they diagnosed ICCA, then they transplant them, compared to the patient results that we're getting on the explant, were incidentally found ICCA. That's why people thought, okay, maybe there are other factors affecting the outcome, including biology of the tumor. So that led to the introduction of the concept of adding neoadjuvant therapy before liver transplant for this ICCA. And this is, again, another important study came from MD Anderson Group and Methodist. So they included patients with unresectable intrahepatic cholangio. Size didn't matter, any size. And these patients were treated with the first-line chemotherapy. At the time, it was gemcitabine and cisplatin. They showed stability of disease for 6 months. They transplanted 6 out of the 12 patients. Very good results, as you see the red line, overall survival. Same group did a little bit larger study. They had 35 patients, same protocol. They intrahepatic cholangio, regardless of the size, chemotherapy. 18 of them were transplanted. And this is why they found overall survival of 57% at 5 years. But as you see, the red line is patients who were not transplanted had a poor outcome. More recent studies really looking at the biology of the cholangiocarcinoma, showing that there are several new targets found, and this is definitely going to change the field and it's going to affect our patient selection process and also the neoadjuvant chemo that they will receive, and hopefully there will be more patients who will be considered, get to the point that it can be considered for liver transplantation, especially addition of immunotherapy in the past year or so for cholangiocarcinoma. This table just shows how so many studies were done looking at the transplant. They didn't have good outcome except for these 2 studies. The first one from 2016, they looked at the size of the tumor, and the second one adding the neoadjuvant therapy really changed the field. ASLD practice guidance definitely in line with the Transplant Society, and basically recommends liver transplantation for early stage unresectable perihilar cholangiocarcinoma. For the earliest stage small intrahepatic cholangiocarcinoma, ASLD at least recommends referring these patients to a liver transplant center to be evaluated. And then for the distal cholangiocarcinoma, so far there's no recommendation, there's no consensus that these patients should get transplanted. The main treatment for these patients is resection, meaning Whipple procedure for the distal cholangio plus chemotherapy, and if they're not candidate for resection, then just chemotherapy and or best supportive care, unfortunately. This is the prospective trial based on the Toronto protocol, again, Gonzalez group, that they're, multi-centers, including locally advanced intrahepatic cholangio. They get chemotherapy. They want to show some tumor shrinkage with chemotherapy. They end up getting a living donor transplant, and hopefully Stanford will join this protocol as well with the addition of our great transplant surgeon, Dr. Sasaki, who will be speaking later. In summary, basically, surgery is the potentially curative option for cholangiocarcinoma plus the systemic therapy in unresectable cholangiocarcinoma. As long as the tumor is confined to the liver, transplant can be an option. If a perihilar cholangiocarcinoma patient is not a candidate for resection, their median survival is only 15 months, as opposed to having a 65% or 5-year overall survival if they undergo transplant. That's why UNOS is supporting this as a priority for transplantation. Basically, we are waiting for the 2 major trial prospective, including early stage and also locally advanced ICCA, and hopefully the data will help us to change the policy in terms of transplantation for these patients. And with that, thank you so much for listening.
Our next talk is going to be given by Dr. Renu Dhanasekaran. She's an assistant professor of medicine, and her research interest here is in cancer biology, and she also sees patients in our liver mass clinic. So she's going to be speaking to us today about HCC and updates in its management. Dr. Dhanasekaran.
Hi, everyone. I think this is like a Deepti conspiracy. She always puts me, happened before, just before the break, and everyone's like, okay, when are we going to get out of here? So I planned, and it's just full of pictures, so it's easy on the hypoglycemic brain. Can you get closer to the mic? Yes. Okay. Okay, so we're going to talk about the more important cousin of cholangiocarcinoma that you just heard about, simply because it's really common, not because it's me talking about it. So I will start with some background. My goal is to highlight the changing landscape. I split that into early and advanced. On early, there's not much to add, but a lot of exciting updates on the advanced HCC. I have one slide on how we are going to look at sequencing these therapies now that we have so many therapies, and then end with some take-home points. So for background, like I said, this is a big, bad cancer. It's the 6th most common cancer in the world, but 4th most common cause of mortality. The etiology is all the other stocks everyone's giving today. You know these ones, hepatitis B, C, alcohol, and NASH is really growing. The incidence of HCC overall is increasing. This is in the context of most other cancers actually decreasing. By 2040, we predict that there will be 1.4 million new cases every year, with almost 1 million deaths every year. In the United States, it's not a very common cancer, but again, in the United States, it is increasing, projected to cause around 42,000 deaths by 2040. So you understand why there's a lot of research and why there is a lot of need to have updates for this cancer. I'll start with a broad overview of how we stage the disease. So then that is the context for how we then treat the disease. In the context of HCC, compared to other cancers, you're going to stage 3 things: the liver disease, the patient performance status, and the tumor itself. For most other cancers, whether it's breast or colorectal, you're going to stage the tumor. You have the TNM, so it's more straightforward. But here, it's very important to know if the patient's liver disease, what stage that is, and how well the patient is, because you have 2 concurrent conditions in the same patient. So in early disease, you have Child-Pugh class A or B, and also in intermediate. The patient has good performance status, so they're doing well. And they have either a single small tumor or up to 3 tumors that we call Milan criteria, that's early. Slightly bigger than that, but still confined to the liver, we call that intermediate. And then you have advanced, where now the liver disease can be more advanced, or the tumor can be more advanced, or the patient is sicker. Here you can have vascular invasion, metastatic disease. We call this advanced, and this is where most of the updates are happening. And then you have terminal disease, where you either have advanced liver disease, so you have Child-Pugh cirrhosis stage C, or you really have poor performance status. In either condition, it does not matter if they have a 1 centimeter tumor or a 10 centimeter tumor, because they are not a candidate for any therapy because they're already too sick. So that would be classified as terminal stage HCC. Okay, I can do it without slides, but maybe we should get it back. Okay, maybe it's a sign, huh? So that's the background for staging. So we go to the changing landscape. This is an old algorithm, which you don't need to learn, but just to give you a context, this is from 2012, so a decade ago. So for early stage here, if you're small, single, not much cirrhosis, you can get resection. More cirrhosis, you can get transplantation. And to get to transplantation, we can do staging treatments like ablation or TACE. If you have intermediate stage, so you're not a surgical candidate, then you get TACE. If you have more advanced disease, then you get one single drug was here called sorafenib. So this is 2012. Now fast forward to 2022. And this is where, again, where most of the advances have happened. So this is how complex it has gotten, which is great news for our patients. A lot of changes did not happen here. For early or very early, you're going to try to get them to resection or transplantation, so surgical cure. If you have intermediate stage, we have more options here. TACE is mentioned here. There's also radioembolization, SBRT ablation. And most of the changes have happened in advanced stage. So you see here a big algorithm, which is where we will be focusing today, and I'll be highlighting several changes that happened here. So let's quickly look at the early and intermediate stage. So if you have early stage, so you have Child-Pugh class A, well-compensated disease, low MELD score. and you don't have too much portal hypertension, so your platelet count's good, you don't have splenomegaly. These are good patients, good candidates for resection, as recommended by both AASLD and EASL. In the West, we maybe underutilized this. There was one study where they found only 5% of all HCC eventually underwent a resection, compared to in Asian countries where there's also earlier diagnosis and some extension of criteria where they use resection a lot. The updates in resection, we are doing a lot of laparoscopic resection, and I think the size criteria also we've been more generous and still getting good outcomes. The second and the big one that we use a lot is transplantation. And here you need size criteria. So you have a single tumor less than 5 or up to 3 tumors, each tumor less than 3. This is called the classic Milan criteria or the UNOS criteria. However, with more updated studies, we are able to downstage patients from slightly larger size and number down to the UNOS criteria. And once you're within that, you still be a transplant candidate. So I have here, you don't have to remember the numbers. The big picture is you can be up to 8 centimeters, up to 5 tumors, and we can still downstage with some local regional therapy and get you to transplant. An excellent 5-year survival, you'll hit 5-year survival of 75%. So it's literally like you didn't have HCC and you just had cirrhosis. Ablation is another option if you're not a surgical candidate but still have early stage HCC. It's a great option, especially for small single tumors up to 3 centimeters. You can hit overall survival of 76% at 3 years. There are some challenges with location if it's very close to the surface or to a blood vessel. However, with microwave ablation, with small tumors, you can get great outcomes. And TACE, or transarterial chemoembolization, it's one of the most commonly used treatment. I think as soon as any referring provider, they see the HCC, they first refer to IR before they even refer to hepatology sometimes. And it's well known that most patients are getting TACE, whether it's early or intermediate stage. 5-year survival for intermediate stage around 30%, with a median survival of 19 months. And this again has been extended by using combination of local regional therapies. I'm only showing chemoembolization because that's the mainstay approved AASLD guidelines and EASL guidelines. But there's also Y90 radioembolization or bland radioembolizations. There are different kinds of therapies that you can use, but these are all for liver-limited disease. So we move on to the advanced stage where you now have either metastatic disease or vascular invasion and multifocal large tumors, not a surgical candidate. Those are the patients we are talking about. So this was the first systemic therapy approved for HCC in 2007. And the context for this is HCC is considered a highly chemo-resistant tumor. So classic chemotherapy like doxorubicin or chlorambucil had all failed already, and there were really no treatment options. If you were advanced HCC, it was palliative care. However, this was a game changer. This is a tyrosine kinase inhibitor in 2007. This is a clinical trial published in NEJM, where the median survival was 10.7 months compared to 7.9 months, which again sounds very trivial. It's an improvement of 2 months. But the point is this is landmark because for the first time you showed that an oral systemic therapy could now control HCC. And there was a lot of excitement, and I think they thought this was going to lead to a lot of new drugs. However, you see this, what we call valley of death between 2007 and 2017, a decade of failed therapies, multiple clinical trials, phase 3, all of them failed. And so this is the new era. The last 5 years have been blockbuster. We've had so many approvals for HCC, many second line, some first line. I'll just name a few which are in 2 different groups here. So you have regorafenib, lenvatinib, cabozantinib. These are all targeted therapies, multi-tyrosine kinase inhibitors. That's one class. They're somewhat similar to sorafenib, cousins if you may, just have slightly different action profile. And then you have this really exciting new class of therapy, which is the immunotherapy. You have nivolumab, pembrolizumab, tremi. So there's 4 or 5 here that are immunotherapy drugs, and that completely changed the landscape because it allowed us to combine them with targeted therapies and achieve remarkable success stories. So just a couple of slides on what immunotherapy is, if you're not familiar with how they work. To make it very simple, cancer cells have cell surface MHC receptors, which have to engage with T cell receptors, then for the T cell to kill the cancer cell. To escape this, cancer cells send a don't eat me signal, which you can call an immune checkpoint, like PD-L1. to the T cell, which then tells the T cell to not eat them. And the T cells become exhausted or ineffective. Now, what we can do is block these don't eat me signals with immune checkpoint inhibitors like anti-PD-L1, anti-PD-1, anti-CTLA4. Once you block that, you remove the brakes on the immune system, so the patient's own immune cells attacks the patient's tumor. We are not giving any chemotherapy here. We are simply releasing the brakes. So I'm going to highlight 2 landmark trials for immunotherapy. This is IMBRE 150, published in NEJM in 2020. This is trying a combination of atezolizumab and bevacizumab. Happily, we're going to call it atezo-bev because it's a mouthful. So the atezo is PD-L1 inhibitor. That's the immune checkpoint I told you about. The bevacizumab is a VEGF inhibitor. So this has been around, has been tried before, was very toxic, but this combination works great. So they took 501 patients, were randomized 2:1 to receive either atezo-bev or sorafenib, which is the first-line standard of care. And we had a 19.2-month overall survival. So that's an improvement of almost 6 months with a very impressive response rate. The overall response rate was 33% compared to 13% for sorafenib. And complete response, as in you gave the drug, you did a scan, and they had no tumor, which, again, was really not seen with patients with sorafenib. We had a complete response of 10% compared to 2% with sorafenib. So this is now the approved first-line therapy for patients who have advanced stage HCC. The adverse effect profile were reasonable because this is sorafenib on the right side, atezo-bev on the left side. You can sort of see on this plot that, yeah, you get side effects, but nothing worse than what you were getting with sorafenib. Hypertension, variceal bleeds being important ones. So if anyone's going to get atezo-bev, they should have a screening endoscopy, and varices should be banded. So the second important trial that just came out last year is the Himalaya trial in NEJM in 2022. Here, they had a combination of 2 immunotherapies which block PD-1 and CTLA4. And with this tremi-druva, you get combination. With this combination, you get an overall survival 16.4 months with a compared to sorafenib, which was 13.8 months. So this has already been approved just recently as a first-line therapy for HCC. So now you have multiple therapies. The question now becomes, how do we sequence them? And this is more a question for oncologists, hepatologists, tumor boards. But just so you understand the concept of how we are thinking about these patients. So the first-line preferred drug is atezo-bev, standard of care, has great response rate, great survival advantage. You also have first-line already approved sorafenib, lenvatinib, and also the new approved combination immunotherapy. How we look at it is, if they are a good candidate for atezo-bev, go atezo-bev. If they have a contraindication for tyrosine kinase inhibitors or cannot tolerate tyrosine kinase inhibitors, you have another great option now with combination immunotherapy. Now, if they progress on this first line, the right side is great news. You still have multiple second-line options. Again, the big picture, there are 2 groups there. The top you can see are the targeted tyrosine kinase inhibitors. Those are oral pills that patients take. And the bottom half are MABs or monoclonal antibodies. These target different parts of immunotherapy or VEGF, and they can be used as second line. So basically, beyond what you already saw, all the clinical trial data I showed you is first line. So when patients fail at that point, they still have multiple options in second line therapy. So the main take-home points, the treatment landscape of HCC rapidly changing, which is great news for our patients. Currently, atezo-bev combination is the approved first line of use. Immune-related adverse events are very common with immunotherapy. I briefly explained how it works. So you're revving up their immune system. Apart from attacking the cancer, you could get autoimmune colitis, autoimmune hepatitis, hypophysitis, many complications, so you need to keep a close eye for that. And lastly, don't have to say it, multidisciplinary team management is key. You can see the landscape has changed a lot, so you need hepatologists, oncologists, interventional radiologists, primary care physicians, endocrinologists, you name it. It's becoming a really important aspect of patient care. And at Stanford, we've been building a great multidisciplinary team, and thank the leadership for that. Thank you.
This one is for Dr. Torok. Dr. Torok, given the incidence of NAFLD and lean NASH, should all patients at a certain age get a FibroScan as part of routine health screening?
Yeah, that's a great question. Currently, I don't think any of the societies propose that. I think we're kind of gearing towards the high-risk groups. And those are the ones that coexisting diabetes, especially poorly controlled diabetes, or special other situations, PCOS, as I mentioned, growth hormone deficiency, hypothyroidism. So not all patients, but I would say that if you have a special, consideration, also including, probably ethnicity and also including age, then yes, then I think FibroScan, if there is a high suspicion, AST over ALT ratio and so on, then these patients should get FibroScans, yes.
Great. Great. There's a question about quantitative Hep B surface antigen and whether there's a use for it in trying to predict patients who would be more at risk of reactivating Hep B if they were being put on a biologic. Is there any clinical utility for Hep B surface antigen in that role?
Excellent question. So the answer is, if your surface antigen is detected at all and you go on a biologic, you probably need to have prophylaxis. There is, if you meet the standard criteria, higher doses, prolonged doses of corticosteroids or something like that. If it's really binary surface antigen positive, negative, I think what is previously been helpful was the surface antibody titer. If it's really, really high, you're much less likely to reactivate unless you get a really potent drug like rituximab, where if you've seen people who have surface antibody, you give rituximab, you'll just see the surface antibody titers just plummet. And these are the people who can reactivate. So don't really use quantitative surface antigen, just use the HBV, just use the surface antigen positive, negative. The AASLD has guidance on this, as does the AGA. The AASLD is a bit more conservative. They don't give as much prophylaxis for hepatitis B reactivation. The AGA's thresholds were a little bit lower. So anyway, we typically use the AASLD. So that means if you're core positive, generally most people, core positive, surface antigen negative for biologics, you usually don't need prophylaxis, but if you just monitor. But if you monitor, you truly have to monitor. I mean, that's because therapies can be augmented. If you're surface antigen positive for most of these, you wind up going on prophylaxis. And I think that's probably that's the simplest approach.
Great, thank you. There's a question here on any thoughts on downstaging with newer checkpoint inhibitors and chemotherapy instead of ablative therapies or TACE? For Dr. Dhanasekaran and Dr. Ghaziani?
Yeah, that's a great question, and this is an evolving field. In terms of downstaging with neoadjuvant, either combination or immunotherapy, and then going for a transplant, some of the concerns have revolved around immunotherapy, because after transplant, you really do not want a revved up immune system, and you're going to treat them with immunosuppression. So the concern has been whether there would be more episodes of rejection if you were to treat. Early pilot studies suggest that maybe that's not a big concern, that we should be able to treat them, downstage them, and then eventually transplant. In our center, Tara has been leading the effort, and we have a protocol where we identify patients at risk for progression and treat them with targeted therapy to try and maintain within Milan or downstage to Milan. That seems like a fairly rational and lower risk protocol. However, if you think about it, a lot of transplant patients have cirrhosis and tend to be more likely child PO B or C. So it's challenging to find the right patient. But the field is evolving, and I think we'll get there where we'll have more neoadjuvant therapies before transplant.
Yeah. I 100% agree with Renu. So we are absolutely doing case by case, selecting patients. We think that they're going to be having a higher risk of dropout while they're on the wait list. In terms of patients who are receiving multiple liver-directed therapy to maintain them within the transplant criteria, those are high risk. Or patients that they start off with more advanced disease and we downstage them, they are also at risk of progression. especially in our region, a patient really have to wait over a year, depend on their blood type, to get transplanted, even with having priority on the list and MELD exception point, but still the wait time is high. But in terms of just having a protocol for adding immunotherapy, Mount Sinai is kind of the leading center now. It's not a controlled trial, but they have their own protocol that they have been, presenting their data, and so far they are not seeing any post-transplant problems in terms of rejection for patients who receive immunotherapy up to about 2-3 months before their transplant. So they definitely evolving field, and we'll have more data, but people in the field are supporting starting immunotherapy in addition to the liver-directed therapy options as soon as possible, again, to get the better outcome.
Great, thank you. Another question on NASH for whoever wants to answer it. Which patients with NASH warrant a referral to hepatology? Does FibroScan make a difference in the referral?
Yeah, that's a great question. So I think I want to reiterate that basically, if you get a FibroScan and on that there is F2 fibrosis or above, I would definitely consider referring the patient, and to confirm, in that setting, a new setting, maybe an MRE, that indeed the fibrosis is high stage. Just want to give you a caveat that wasn't in the talk, that stiffness is not only fibrosis, it doesn't equal fibrosis. So let's say you have a patient who had gone in an alcoholic binge and they also have NASH, they can have really high stiffness if they go like within a week to get this done, and they come back to the clinic and the stiffness will be a different number. So it's worth to get the history and confirm the testing. So again, I would refer the high-risk patients who confirm to have NASH with fibrosis, at least F2, in kind of a GI and hepatology setting clinics.
Great. And a question for Dr. Dike. For patients who are transitioning from pediatric GI to adult hepatology clinics, any pearls of wisdom on how to make that transition a smoother one?
So that's a great question, and I think one that a lot of our pediatric colleagues are faced with a lot. A lot of our patients are transplanted when they're young, so a lot of their care for years and years of their lives are driven by their parents, and so we run into a problem where we have teenagers who are at the age that they should be able to transition, but because of they've been chronically ill all of their lives, parent relations, they have parents who've constantly kind of been the primary source of caregiving, and then other things that kind of arise throughout childhood, that transition is not as smooth as it should be. So I know in our institution and some other institutions, they're looking at how do we best transition those children. And so really for us, it really starts early. So it's, some of it is creating, we have dashboards or questionnaires that we create, or even informally when we see patients, just asking them, do you know why you were transplanted? Do you know your medications? Do you know who's your coordinator? Do you know how to reach them? Things like that, just so that they can be a little bit more aware, especially these patients who are transplanted younger, a little more autonomy. But I will say that it's not perfect and it's not excellent, and I think our adult colleagues probably can also speak to that as well. But it's something that we are working on because it really is an issue.
Great, thanks. Any other thoughts on that? Okay. We'll take one last question, and then I think we'll go to break because we're running a little bit behind schedule. There's a question here about, do you recommend HCC surveillance for patients with F3 on FibroScan with NASH-related liver disease in your clinical practice?
Yeah, so that's another, I personally would, that's my personal bias. Let's start with that. And the reason is there's some data suggesting that some patient populations are at risk. However, as I mentioned, we do not have clear guidelines in that sense. ADA recommends type 2 diabetics, high-stage fibrosis patients to screen for HCC. However, it's not backed or confirmed yet by other societies. So that's kind of the gray zone in this country right now. But I would say yes, because I just want to mention that of all HCCs that come from NASH, about 20% comes before cirrhosis. So, and if you add up the numbers, especially if kind of time progresses and now it's 2030, that number will be really high. And so these are the patients we often see with large lesions in the liver clinic who have not been screened because, well, there were no guidelines. So I would say, my personal bias, I would do it, yes.
Great. Any other thoughts?
Yeah, if you are F3, if you get that on FibroScan, it's just to reiterate what Dr. Torok said, you need to use other measures and really evaluate that person. So if it's F3, you want to really make sure it's F3. But because there's F3 and there's F3. Some F3 might be because they went on an alcohol binge just before, and that one necessarily may not need screening. But if everything is pointing to F3, then these are people we generally screen.
Great.
I agree.
I think we'll leave it at that. Thank you to all of our speakers for your wonderful talks. Round of applause.